So we can start now. We are live on YouTube as well, and it's 5:30.
Good evening, all. Unfortunately, I can't open my video. Can you hear me properly?
Yes, loud and clear.
Okay. Without wasting time, let's go to the task given to us. Now it's okay. Right. Good evening, all. I take this opportunity to welcome you all to the ongoing web series conducted by the Sarcoma Education Foundation in association with IMSOS, TMH, and the Bombay Orthopedic Society. Me, as a orthopedic oncologist who does only orthopedic oncology, get very less references from for GCT patients, and I get more of sarcoma patients to operate. I'm sure that's the experience with most of the orthopedic oncologists all over the world. That makes us aware that this disease, though benign, but with multiple issues that can happen, is being treated by almost all orthopedic surgeons all over the world. So I think this session is very important in the point that we need to give a proper idea on the basic principles how to manage this benign but locally aggressive disease, which are commonly being treated by most of us. So without wasting time, I would like to hand over to Vineet Kurshingal, consultant at ROH Birmingham, for the rest of the program. Over to you, Vineet.
Thank you, sir. I take this opportunity to thank Sarcoma Education Foundation, IMSOS, and Bombay Orthopedic Society for giving this session on educating the next generation on management of primary bone tumors. This is the fifth session today on this teaching academic fiesta, and we've got a esteemed number of guests, national and international faculty who are going to be joining us for our talks. We have basically simplified giant cell tumor of bones today in terms of radiology, principles of management of extremity, role of denosumab, and we have a panel discussion where we will be covering common tumors with giant cell tumors as their diagnosis and how we manage them, and a quiz for students all over who would want to join us. I can see we have a strong number of participants, both internationally, who have joined us from different parts of the globe, and a lot of students from India as well, along with a lot of faculty. I would like to thank all of them for joining in. And without taking much more time, may I hand over the mic to Dr. Bochu, who's been giving us a brilliant talk on radiology of giant cell tumors of bone and its common mimics. Just to give you a brief introduction, Dr. Bochu is a professor in musculoskeletal radiology, and he is one of the leading musculoskeletal radiologists in the United Kingdom, and he's going to be giving us a brief idea on giant cell tumor of bone. Over to you, sir. Dr. Bochu? Yeah.
Yes, to unmute, Vinay.
Dr. Bochu, I think you are on mute.
Yeah. Okay. Can you hear me now?
Yes, sir, loud and clear.
Yeah. Sorry. Thanks for the invite. Thanks to Vineet and Sarcoma Foundation for the invite. So over the next 10 minutes, what I'm going to do is I'm going to discuss the imaging features of GCT, predominantly on X-ray, but also on MR and other imaging modalities. If you want to know more about GCT, you can check on our free website and app. It's got around 4,000 musculoskeletal cases, and I think there are around 500 GCT cases on that, and it's a free website and app. So if you look at GCT, what is GCT? GCT is a benign locally aggressive tumor, and it is seen in skeletally mature patients. What I mean is that if you look at the radiographs, the epiphysis will be fused. It's based in the epiphysis. There are only 4 lesions in the epiphysis, and based upon the age, you can come to the diagnosis. If you have an epiphyseal lesion, if the patient is less than 2 years, it's infection. 2 to skeletal maturity is chondroblastoma, and after skeletal maturity, it is GCT. In elderly, if you see a lesion which just looks like GCT, it is a geode. The most common sites are the distal femur, proximal tibia, and distal radius. And the other key important features of GCT is it's always eccentric. But you have to understand if it's a narrow bone, for example, the radius and the fibula, it can be central. They don't have any matrix. They have a geographic pattern, and in some cases you can have a sclerotic margin. Sometimes, in some cases, it can be a bit ill-defined. Periosteal reaction is not present, and if it is present, it's normally because there is associated pathological fracture. Sometimes you can have a solid component. Majority of the times it's solid, but sometimes you can have a cystic component as well. And if you look at the radiographs, then you can see some trabeculations. It is important to note that the cartilage normally acts as a barrier. So hence, most of the times, involvement of the joint itself is very rare. And you can have multicentric presentation of GCT, but it's very rare, less than 1%. If you look at on the MRI, it can have varied appearance, but generally the features will be low to intermediate on both T1 and T2. If you have fluid levels, as what we say is secondary ABC, you can also see in GCT. And GCT, in fact, is one of the commonest causes for secondary ABC, accounting for about 40%. And if you see fluid levels, depending upon the sequence, you can either see low or high on T1 or high on T2. Though GCT is benign, locally aggressive tumor, you can see metastasis in some cases. And if you see metastasis, extremely rare, it's less than 3%. But these are more common if you have a GCT of the radius or sacrum, or if there has been radiotherapy. The main modalities that you would use for imaging GCT are radiographs, MR. Those are the key. Previously, people used to use bone scan. We don't use bone scan at all. A roll of PET-CT, we don't use PET-CT or PET-MR. So these are the most common. So, and if you have a GCT of the radius or sacrum, it's always better to just get a chest X-ray. You can get GCT in the spine as well. And if it's in the spine, normally you will see an expansile lesion. The signal features will be similar to that you see on an extremity bone. You can have a cystic component. If it is in the sacrum, it can extend into the sacroiliac joint, but it has got a predominant predilection for the vertebral body. And you can have associated collapse. Sometimes you can have posterior element involvement as well. In some patients, you can diagnose them on CT. So for example, patient is having CT for something else and you would have picked it up. And if you see it on CT, the lesions will be typically isodense in comparison to muscle, and they can show enhancement on post-contrast imaging. If you look at it on bone windows, it will be lucent just like on radiographs. So let's look at some cases. So this is the classic presentation. You will see a lucent lesion involving the distal femoral epiphysis. In this case, is extending into the metaphysis. It may go all the way to the subchondral bone, but does not extend into the joint. It's eccentric, a narrow zone of transition. And you can see that the physes are fused. So it's not difficult to make the diagnosis of GCT in this case. And if you look at on MRI, if you look at on T1, it's predominantly low to intermediate signal. And on fluid sensitive sequence, it can be low or high depending upon the cystic component.
Yeah.
Another patient here, we can see an eccentric lucent lesion involving the proximal tibial epiphysis extending into the metaphysis. Again, please note that it's eccentric, going all the way to the subchondral bone. Again, it's not difficult to make the diagnosis. In this case, obviously, you can see that this patient has got a pathological fracture. And if you do MRI in this case, for example, you can see a large soft tissue component as well posteriorly, but note that there is no intra-articular extension above the subchondral bone, though there is a small component extending anteriorly. This is a bone scan from many years ago, and if you do a bone scan, it will be hot. Sometimes GCT can grow at an aggressive rate. For example, this is a patient, again, note eccentric lucent lesion going to the subchondral bone, had knee pain, and then he had a follow-up radiographs. In 3 months, there was some delay. And note how big the tumor is now. So this tumor has, sometimes they can grow at a rapid pace. But still, the diagnosis would remain GCT because of the nature, because of the location. It's not difficult to make the diagnosis. And again, note a small cystic component. As I said, you can see GCT in the other bones. For example, in this case, the fibula, and in fibula, unlike the tibia, it's normally central. Again, on MRI, you see the low signal on T1. And on fluid sensitive sequence, you can see a small cystic component as well. You can see it in other bones. For example, this is a GCT involving the talus. Again, the features are of a solid and cystic component involving the talus, going all the way to the subchondral bone. And this patient was 30, so the diagnosis was pretty easy. You can see it in the small bones. In this case of the triquetral, and again, a case of GCT. Remember, the greater trochanter is an apophysis, so it's akin to the physis. So the lesions which are predilection to the physis also involve the greater trochanter. In this case, lucent lesion, again, note the physis are closed, so skeletally mature, case of GCT. GCT of the radius, yes, it's not very uncommon. And in this case, you can see a large lucent lesion. And in this case, it's central. As I said, in fibula and in radius, it's predominantly central. Again, predominantly low on T1 and on fluid sensitive sequence with a small cystic component. In the spine, what happens is that you see a lesion predominantly in the sacrum in this case, and it's eccentric. So your two differential diagnoses would be GCT or a nerve sheath tumor. So these are the two differential diagnoses. But looking at the sequential images, you can come to the diagnosis. And in this case, this was a GCT. Another case of GCT involving the right sacral ala. Sometimes you can see fluid levels predominantly within the lesion. As in this case, you can see multiple fluid levels, and the physis is closed. So the most common cause for this would be GCT with secondary ABC. This is a case from a long time ago, and hence the bone scan was available. Again, it will be hot. Another patient, eccentric lesion going to subchondral bone, another GCT with multiple fluid levels. Whenever you follow up a patient of GCT who has had denosumab or surgery, the reason why we follow it up is by radiographs and MR is to look for recurrence. And it's important to note that the recurrence can be seen in up to 25%. And most commonly, it's seen around the site of the bone grafting or the cement. As in this patient, a patient with GCT who had curettage and cementation, and few years later, you can see a large soft tissue component and lucency around the cement as well. MRI shows extensive recurrence involving around the cement as well as into the soft tissues. What about this one? We've got a lesion involving the calcaneum. Calcaneal GCTs is also not very uncommon, but here it's predominantly low signal on T1 and fluid sensitive sequence. So whenever it is low on extremely low, or in any case of GCT, one of the important differential diagnosis is brown tumor. So you have to always check serum calcium. So this was a biopsy proven brown tumor. You can see brown tumors in other areas. For example, in this case, again, eccentric lesion, narrow zone of transition, subchondral in the distal femur. Diagnosis would be GCT. It's predominantly low on T1, and in biopsy, it came out as brown tumor. What about this one? This is a relatively elderly patient, and you can see advanced OA involving the medial lateral compartment, and you can see a central lucent lesion involving the proximal tibia. So, and the patient had a CT. This is a case from many years ago. You can see, but it's central, and the patient has underlying OA. So it is not GCT. This is a case of geode or subchondral cyst. And you can see geodes in other areas as well. For example, this patient with advanced radiocarpal degenerative change referred to our center as a GCT, but obviously this is a geode. And on MRI, you can see it's predominantly cystic with the communication with the subchondral, with the joint. So remember, geode is also one of the mimics of a GCT. What about this one? You see an eccentric lesion. You see an eccentric lesion involving the proximal tibial epiphysis with the fluid level. In this case, the physis is fused. So this patient is around 18 years old. So this was biopsied and it came out as a simple ABC. But whenever you see a lesion like this, sometimes on the biopsy itself, it can be ABC, but when the curettage, they will see small foci of GCT. What about this one? A large lesion involving the proximal tibial physis extending into metaphysis. You see the physis is almost closed. So the patient is about 17, 18. On MRI, you see on T1, it's low. But on fluid sensitive sequence, there is extensive perilesional edema. If you see extensive perilesional edema around an epiphyseal lesion, diagnosis should be chondroblastoma. So this was a large chondroblastoma. Another case of chondroblastoma involving the proximal tibial epiphysis, but in this case, it's easy because the physis is not closed. And on MRI, you can see florid perilesional edema. So this is a case of chondroblastoma. Sometimes, as in this case of a patient who is 25, a distal tibia, lucent lesion, eccentric, so GCT radiologically, but on MRI, you can see multiple fluid levels. We biopsied this. On biopsy, it was ABC. On curettage also, it was ABC. But if you ask me, radiologically, the diagnosis should be GCT with secondary ABC. What about this one? Another patient with a small lucent lesion involving the medial tibial condyle, eccentric. So diagnosis is GCT for us. On MRI, multiple fluid levels. We biopsied this and it was ABC. We could not find the GCT component. But radiologically for us, unless proved otherwise, this is a case of GCT with secondary ABC. So these are my references. I hope that was a quick recap of the imaging features of giant cell tumor, predominantly on radiographs, but also on MR, and keep in mind the other differential diagnosis as well. Thank you.
Thank you once again, Dr. Bochu. I was just trying to check in the chat box if there are any other questions for Professor Bochu, and I think you answered all their questions and queries. Moving on, if you have any other further questions, we can discuss them during the panel discussion as well. I would like to now invite Dr. Suman Bairagowda, lead consultant at Narayana Hridayalaya, Bangalore, who is one of my seniors and mentors in Tata Hospital, Mumbai, during my fellowship days. I would like to invite him for his talk today on management of extremity giant cell tumors of bone. I think he's going to explain everything with related to current evidence and the best way treating them moving forward. Welcome, Dr. Suman. Over to you.
Thank you, Vinit. Am I audible?
Yes, you are.
Yeah, so I am outside. Maybe the network will be a little patchy. So if any issue, let me know. I will switch off the video.
Okay, okay.
Okay, so thank you, Vinay. It's difficult to cover all GCT in 10 minutes, but I'll try to brief and give a picture of management of extremity GCT. So we know this tumor from pretty long time, more than 200 years, but the recurrence rate is pretty high, varying from 10 to 40%. So let's see how can we reduce this. So as Dr. Rajesh mentioned, there are a few important investigation we need to do before doing the procedure. The first one is the X-ray. We know about Campanacci grading, grade 1, 2, 3. So why it's important? Higher the grade, when there's a soft tissue extension, the disease clearance will be difficult. So this will have high chance of recurrence. Campanacci 3 will have high chance of recurrence. So followed by MRI is mandatory. So this gives an idea about the location of the tumor, the dimension, relation to important structure, and the quality of bone. And the most important thing, but most time the neglected one, is the biopsy. So here is a case, X-ray and MRI looks like clear GCT. The patient was operated without biopsy and a curettage has been done. When the material was sent, it turned out to be osteosarcoma. So patient required amputation after this. And one more case, so there's a lesion you can see in the distal femur. The MRI was done in one of the main centers in Bangalore, which was reported as giant cell tumor. So when we did a biopsy, it turned out to be chondrosarcoma. So it's always, even on imaging, if it looks like JCT, it is mandatory to do a biopsy. And the next important thing, as Dr. Rajesh mentioned, it's always important to have an alkaline phosphatase level because it's very difficult to differentiate GCT from Brown's tumor. So once we have all this investigation, now come to the treatment part. So the most common surgery, what we do is curettage. So the first question is, when do we do curettage? So we do curettage when after doing a complete clearance, if you feel there is adequate bone left to do the reconstruction, so that is the patient or candidate who is fit for doing a curettage. So what are the steps of curettage? So the most important is biopsy. So the planning starts from the biopsy. So we have to make sure that we enter through the soft tissue component, not contaminate the bony component, because that is the structure which we are going to retain and do the reconstruction later. So here you can see there's a tumor which has a soft tissue component in the posterior medial aspect. Instead of doing biopsy from the medial aspect, I have done posterior medially and open through the soft tissue component in the posterior medial, and we have done a reconstruction. So a step by step I take. So this is a GCT, biopsy proven. Patient had CT scan outside, so we didn't do the MRI. So we do under tourniquet because we know that GCT is highly vascular and it's going to bleed. We don't get a proper feel if we don't use a tourniquet. So always the soft tissue component should be excised with good margin all around, like how we excise a malignant tumor. So that's where we can reduce the local recurrence. So make sure that we dissect the soft tissue component and pack the surrounding area with hydrogen peroxide soap mop so that there's no contamination around, and cut and take the soft tissue component completely, because it's very difficult to cure it again. It's a soft tissue and there will be high chance of local recurrence. So once it's done, the disease is scooped out. So that's the simple curettage. You can see there is disease still inside. So if we stop the procedure at this level, there will be very high chance of local recurrence. So what we do, the most important step, we use a high speed burr with minimum more than 20,000 RPM and break all the septae and reach out to each and every corner and make sure that we take out the tumor all around. So the window should be adequate. You should be able to see each and every corner of the tumor so that you can get a complete clearance. So we spend good time here, so because it's the most important step, and make sure that the disease is completely removed. So this is after extended curettage. So you can see the difference between a simple curettage and extended curettage. So we have gone extensively, broken all the septae, reached each and every corner of the tumor, and that's a healthy bone you can see in and around. So this is one of the study which shows that the local recurrence is significantly comes down when we use this extended curettage with a high speed burn. And coming to adjuvants, so there are a lot of questions whether the adjuvants are useful or not. The main thing which works is how we do the curettage, how we get a mechanical clearance of the disease. Adjuvants may help to a certain extent, but there are a lot of meta-analysis which has shown that the adjuvant doesn't make much difference. So what makes the difference is how we get the complete disease clearance. But in case if you want to use the adjuvant, you should know the property of these adjuvants because they are tissue toxic. So this is one of the case where the surgeon has poured liquid nitrogen into the cavity without knowing the property of it. So it has completely damaged the bone and the skin, and patient landed up with amputation. So I use hydrogen peroxide, that is simple and safe as an adjuvant. So once the disease clearance is done, now the reconstruction part. So we have two ways to reconstruct. Either we can use bone or you can use cement. This is commonly given in all the textbook. We know the advantages and disadvantages, and sometimes you can combine these two to form a sandwich technique. Each procedure has their own advantages and disadvantages, and we have to pick the patient based on the location of the tumor, amount of the bone left, what is the age of the patient, and amount of the bone, quality of the bone left. So these are the two patients where I have done a bone grafting, and this is a patient, similar patient where I have done cementing. So oncologically and functionally, they almost give similar outcomes. So we have to worry more about getting the disease clearance than thinking too much about whether to use the bone or whether it's to cement or whether it's to do a sandwich technique. So pathological fracture with minimally displaced bone is not a contraindication for curettage. So here you can see intra-articular fracture. So we have done an extended curettage and stabilized with plate and cement. So having a recurrent GCT is not a contraindication for curettage again, The same principle holds good. If there is adequate bone left, we can still go and do a curettage and save the joint. So in this case, recurrent GCT, we have done a curettage and filled with cement, and this is the function of the patient post 3 years of the surgery. So the tumor like this, pretty big, which has completely destroyed bone, where we know that after doing the curettage, we won't be able to reconstruct, need excision and reconstruction. So most common reconstruction method, what we use is the processes. So this is the case where we have excised the proximal tibia and replaced with artificial metallic bone. And one more case where there's a huge tumor in the proximal femur, we won't be able to do a curettage here, where you have excised the tumor with complete margin and replaced with a metallic bone. So tumor in expandable bones, for example, in the proximal fibula, distal ulna, we can excise the lesion and no reconstruction is required. So coming to distal radius, we know that distal radius DCTs are quite aggressive. There is high chance of local recurrence. So we use this criteria to plan either to do a curettage or excision. If tumor is involved in the articular cartilage, or if it's destroying more than 50% of the cortex, or it has soft tissue in 2 planes, if any of these 2 criteria is present, we prefer to do an excision. So this is the criteria we use for distal radius. So once we do the excision, there is various options to do the reconstruction. One of the option is excise the distal radius, take out the fibula and do the arthroplasty, where you can save the wrist movement. Other option is shift the neighbor bone ulna to that place and do a arthrodesis. Now, do we have time? Shall I play the video or shall I stop? Hello.
I think you're just reaching.
So you can
time.
show how long is the video?
It's around 3 minutes. I can just forward.
Yeah, I think you should be okay.
So this is the GCT. So it's a GCT involving the distal femur. So you can see the Campanacci grade 2. The bone is expanded, but there is no soft tissue component. So that's a tumor you can see. So biopsy scar is excised so that if there's any contamination, we are removing it. And as I told you, the puncture is done under tourniquet. So lift the vastus medialis muscle, reach the bone. So that's the soft tissue component you can see here. So that's a biopsy scar left with it. So now we place the hydrogen and we keep a mop and keep all the contaminated instrument there. And once the curettage is done, we are going to dispose them and use a fresh instrumentation set. So you can see I have put a hydrogen peroxide mop in and around and excising the whole soft tissue component en bloc. Yes. So a little hard part of the bone, you can cut it and excise it. So that's a soft tissue component excised. So now you can see the disease. So with the help of scoop, we can remove the tumor and take out with the nibbler, make sure that we don't spill it and contaminate the surgical area. So use the scoop to try out as much disease as possible. So that's the end of the simple curettage. Follow it will be the extended curettage where we use the high-speed bone. You can see the high-speed bone with 60,000 RPM. So make sure that we break all the septae, each and every corner of the tumor. So spend adequate time, make a pretty big window so that you should be able to see each and every corner of the tumor. So you can see gradually increase the window size so that I get the complete vision. So once it's done, as I told you, used hydrogen peroxide and pulse lavage and thorough wash is given. So that's a cavity you can see after doing the extended curettage. So here we can use either graft or cement. So we have used cement in this place where I put a plate for extra stability and put the cement inside, pack the cement inside. So that's how post-op X-ray looks. Thank you so much.
Thank you, Dr. Suman. I think we're running a bit short on time. Can we just take one question before you can log off? I know you are almost about to catch a flight.
Yeah, please.
One of the questions asked is from Teresa Kartika. The question is, how do we ensure the minimum level of heart tissue needed to perform extensive curettage for GCT? Do you have a surgical criteria, or is it a gut feel when you go in for reconstruction?
So there is no exact criteria like where we say that, okay, only there is 80%, 70%, but usually we take that after doing an extended curettage, if you're left with 2/3 of the cartilage. So then we can go and do an extended curettage and save the joint.
Thank you. And would you recommend any tips on improving the yield on your biopsy for giant cell tumor of bone?
Pardon?
How would you know would you have any tips on targeting a particular area for doing a biopsy? Do you need an X-ray and an MRI, or are you happy with just an X-ray before?
No, it's standard protocol as I told you. We have to get an X-ray, MRI, then we have to plan from which side we will be entering, make sure that we are doing a biopsy from where there's a soft tissue component so that we are not damaging the good bone which is left. And also based on the MRI, make sure that if there is secondary ABC component, we have to avoid that component area and target the solid component. So always X-ray, MRI followed by biopsy.
Okay. And one last question. Do you normally do routine X-rays or imaging of the chest for primary giant cell tumors of bone?
Yes, because Dr. Rajesh mentioned they can have metastasis in 2 to 4%. So we get a simple X-ray before the surgery, and I repeat X-ray once in 6 months for first 2 years in the follow-up.
Okay. Thank you. Thank you, Dr. Suman, for an excellent talk. I think we're running short of time. I'm going to go off to the next session, which is going to be myself, and I'll be covering the topic of role of denosumab in giant cell tumor of bone. Dr. Suman.
Yeah. Before you proceed, there are a few unanswered questions on the chat. If you can just address those before moving to your presentation. So there was one question from Dr. Ashish about how to increase the yield of biopsy in GCT.
I think Dr. Suman Dr. Suman, are you?
Yeah, please tell me.
One of the questions from Professor Ashish Gulia is, any tips in improving the yield of biopsy in GCTs?
Yes, the most important, as I told you, we need to see the MRI and plan biopsy accordingly. And second, better to scratch the wall and aspirate the material. As I told you, GCT can have secondary ABC components. Sometimes we may not get a solid component. So better to scratch the wall and aspirate the material so that we are not missing any tumor cells.
Okay. And one more question from Professor Ashish. Is recurrence and path fracture an indication for resection in giant cell tumor of bone?
Absolutely no. As I mentioned, for recurrence, the principle holds same as the primary case. If you can save adequate bone where you can do a reconstruction, you can go ahead and do a curettage. So same with pathological, minimal fracture with minimal displacement, still we can go ahead and do a curettage. Yes, the chance of recurrence will be little high compared to the regular cases, which has to be explained to the patient.
Okay, thank you. I think we'll proceed to the next presentation. If any other questions, we can take it at the time of the panel discussion. Thank you, Dr. Suman. Hope you have a safe journey.
Thank you.
Can you stop sharing? Is my screen visible?
Yes.
Vineet, before you start, can I take just 1 minute?
Yes, sir.
Hi, this is Dr. Gulia, and I want to thank each and everyone officially. Thanks to Dr. Subin Sugat Bhaskar for leading this entire program. Thanks, Vineet, for coordinating and making the program. And I want to thank each and every faculty and panelist who have spared their time for this niche idea. Sarcoma Education Foundation is essentially a non-profit organization which has taken a step towards improving the education related to sarcomas, not just in India, but across globally. And this initiative, which is Nurture the Future, is is a new initiative where we will be covering musculoskeletal oncology in 12 classes. Every year we will repeat, and I request each one of you who's attending, it's my sincere request that please spread the word across to all residents and young consultants, not just in India or subcontinent, but abroad as well, that every Saturday in the evening, 5:30, we'll be doing this unique sessions, and your feedback will be very, very essential for us to improve this, and I hope it will benefit everyone. Thank you so much, Vineet, for taking time out of your talk, and thanks for coordinating the entire show. Thank you.
Thank you, Professor Gulia. I would like to start again by thanking the Sarcoma Education Foundation for this series on musculoskeletal oncology. I've been asked to talk about denosumab and its role in giant cell tumor of bone. Just before I start, can I confirm I'm audible?
Yes, you are. Please go ahead.
Yeah. So I'm Vineet. I'm one of the consultant orthopedic oncologists working at the Royal Orthopedic Hospital in Birmingham. Denosumab is quite an important entity nowadays in the world of giant cell tumors of bone, because people use it judiciously. Sometimes people misuse it. Exact indications may not be known to a lot of people across. People working at sarcoma centers would be having a protocol for following. The whole concept of this talk would also help people making or rationalize decisions with regards to managing giant cell tumor of bone and its role with denosumab. So this is obviously a novel modality of treatment. As everyone knows, just a brief introduction, it's a fully monoclonal antibody. It targets the RANK ligand and prevents its fusion with RANK, therefore preventing osteoclast-related resorption. Dose is 120 milligrams subcutaneously, and 0, 7, 14, and 28, and then monthly is the first loading dose, followed by maintenance dose, which we have monthly. It is not a definite treatment. It's usually used as an adjuvant, but that has opened up its views over the past couple of years. Long-term follow-up is required, and issue is cost. So with this talk, our aim is going to be, does denosumab change the treatment protocol for giant cell tumors of bone? Can you make an inoperable tumor operable? Can you or should you downgrade from tumor needing resection to a tumor that can be curated? So standard indications for people is denosumab helps facilitate curettage, convert resection to curettage, facilitate resection, and extended indications. I'm giving you all case examples so that it's easier for people to understand. Facilitate, this is a classic Campanacci 2+ giant cell tumor of bone, proximal tibia. This was borderline resectable, but obviously considering the patient's age, we decided if we could salvage the joint. Gave him 4 doses of denosumab, and this was the response. And considering that the articular surface was maintained, soft tissue component was well ossified, we proceeded towards a curettage and cementation and plating. Another case example, Campanacci 3 with a soft tissue component, but this was appearing only in one plane. Decided to do an excision of the soft tissue and curettage if possible, however, based on response with denosumab. And you can see if this is following 6 doses, the soft tissue component was well ossified, the rim was sclerotic, and we proceeded towards a curettage, cementation, and plating. Converting resection to curettage is cases where we think upfront resection may not be feasible considering the patient's age, long-term side effects, and we would obviously give a chance to every patient before we decide on doing a en bloc excision. This is a case from the Royal Orthopedic Hospital. 14-year-old girl presents with biopsy-proven giant cell tumor, thin rim of bone in the left femoral neck. Multiple options. If you curette, will it collapse? Will it recur if you do it upfront? Should you give her any form of denosumab? We proceeded with giving her 4 doses of denosumab and curated and did a fibula grafting, and she is fine. This is a 34-year-old lady, Campanachi 3. As you can see a soft tissue component on the lateral side, biopsy-proven GCT, MR scan shows serial imaging. Patient again was given denosumab as per our protocol, and then we proceeded towards curettage and cementation. We were quite lucky because all series after the initial experience with denosumab is that the rate of local recurrence was almost close to 44% following denosumab. So people are now hesitant in terms of deciding if denosumab should be given as a neoadjuvant option for all cases or should it be done only for select cases. This is the review of literature which shows that all patients who have had denosumab and curated have the higher local recurrence group compared to the ones where you had upfront resection. So we at ROH, we follow a policy where we decide on day one when we see the scans whether this patient should be for denosumab and what is the indication of denosumab. This is a 29-year-old gentleman who presented with a path fracture, right distal femur, and we basically gave him denosumab with a intent of resection once he responds following the treatment. He had his biopsy done. Denosumab, this is following 13 weeks of neoadjuvant therapy, and we proceeded towards a distal femur resection, and he's fine now and he's in standard follow-up. This is another lady, 32-year-old lady, who presents with a Pratt fracture, intra-articular distal femur, biopsy-proven GCT, 13 weeks of denosumab with a distal femur resection. So this is the protocol we generally follow at ROH, where it's a 1 or 2. I think it's quite standard from today's meeting that curettage is the option. It is the ones with the Campanachi 3 or ones with path fracture where we have a concern whether what is the right way of treating this moving forward. Coming to the last indication of denosumab is the extended indications, which is surgically undissectable tumors, surgery associated with increased morbidity. For example, this is when I was during my fellow days when I was in Tata, where you have tumor going into the intrathoracic compartment, you have tumors going into the spinal cord, where en bloc resections are associated with significant morbidity. Tumor going into the thoracic chest wall, where resections could be concerning. This is a few case example of a 17-year-old girl who presented with diplopia to our unit, and they found a giant cell tumor of Boyne along the medial wall of the orbit. Biopsied, obvious choice was to offer her denosumab, and she's now on 5 years follow-up doing well. Case examples of surgery is with patients with spinal giant cell tumors of bone. Historically, people would be reluctant in trying out non-operative options, but since the adjunct of denosumab, we have patients on close to 9 years follow-up with stable disease and with all motor function intact. Another similar case presenting with sacral giant cell tumor. You can see significant if this patient needed a resection, you would do a total sacrectomy, which would associate with significant amount of morbidity. This patient is now on 10 years follow-up with stable disease. We obviously tapered the dose of denosumab, but the patient's doing well. This is a case example of during my fellowship days when I was in Tata, where you presented with tumors similar, started on denosumab, and 2017 patients have stable disease. So indication of denosumab is quite important rather than using it for all cases. Pain resolution is another. This is a patient who presented with significant pain, neuropathic, and this was the presentation. Patient was started on denosumab, and you can see that the rim is ossified. The patient unfortunately developed some complications because of denosumab, and his clear statement to us was, "You can take all my teeth out, but please don't stop me on denosumab treatment." That was what he understood with the treatment he was offered. Denosumab has an additional setting in the use of metastatic disease of giant cell tumor of bone, where you have less surgical options considering the morbidity required with thoracic dissections. And this is a patient obviously with sequential denosumab and angioembolization showing stable disease. Management of metastatic GCTs is obviously for resectable mets. We would obviously offer resection. For which large unresectable mets, we would keep a balance about affordability, cost, and what it encompasses offering her surgery. These is extended indication which we follow in the UK because cost is not a constraint for most of our patients. This is a 26-year-old girl who presents with a biopsy-proven giant cell tumor of bone, who, because this was the Campanacci 3, our indication was for a resection because of the high risk of local recurrence in this case. This patient obviously was counseled regarding the treatment options. She decided to go on for denosumab. She's on 12 months follow-up, but she understands if she decides that she wants surgery, then the option would be a en-bloc excision of the proximal humerus and reconstruction. So she wants to keep her function till she can, and if she decides to start a family, we would have to stop and then reassess her for surgical options. This is a 40-year-old gentleman, again, biopsy-proven giant cell tumor of the posterior ileum. He didn't want surgery because he felt it was too morbid. We started him with a trial of denosumab. He was doing reasonably well, but unfortunately, he developed some complications with his jaw, and we had to stop him on denosumab. And finally, we offered him an excision where we did a navigated posterior ileosacral resection and a graft jacket reconstruction to prevent hernia. So in short, denosumab is fantastic for GCTs, 98% response rates. They completely ossify. They're useful for extended indications, but the dose frequency and duration still need to be confirmed. Contraindications or issues which you need to consider: females can't get pregnant when on it. Patients have to be sequentially monitored with calcium levels. They need to be supplemented. If you do stop it, an average time of recurrence is about 9 months. So no one knows when to stop or what is the dosage you should give. No one knows the long-term effects, but one of the most rare side effects of osteonecrosis of jaw and atypical fractures is something which needs to be considered. So we need to still find out whether there is an alternative or whether we know how to dose the drug. But at this point, it is a wonderful drug for treatment of unresectable tumors. Should we change our plan? We would stick to it because, as we can see with all the series I've shown today, they are truly useful in inoperable sites, but needs lifetime treatment. Side effects is something which we need to consider. If you do plan to operate, we recommend giving a shorter course of about 13 weeks and then decide for resection unless the patient wishes against it. Identifying what is GCT and its effect becomes increasingly difficult. And this is what we need to, as a oncology specialty, look for: clarifying the dose and frequency in inoperable metastatic giant cell tumors, identify the true side effects and associated risks of resistance and probably complications associated with long-term role of denosumab. Like I say, we're all sarcoma trained surgeons, but the strength of the team is always each individual member, and the strength of each member is the team. This is a quote by Phil Jackson, a very successful basketball coach who led the Lakers to multiple team events, but the concept of an MDT essentially entails this. I would like to thank you from the Royal Orthopedic Hospital for giving us this opportunity, or giving me this opportunity to present on this talk today. Thank you.
There are a few questions on the chat box. So if you can just take that before we move on to the panel.
I would take the question from Dr. Levin. Hi, Levin from Kuala Lumpur. With regards to denosumab, do you experience any difficulty in extended curettage given that the bone is hardened? Absolutely. That is why I said if your decision to curette, if your intent of treatment is for curetting a borderline tumor, then we would recommend giving a short course treatment. When I say short course, 2 to 3 doses of denosumab and then offer curettage. I come from a different school of thought because I was trained at both Tata Hospital in Mumbai, and now I work as a consultant at the Royal Orthopedic Hospital in Birmingham. There is no concrete evidence to say that denosumab is going to help you with your curettage, because all the series which have been demonstrated post denosumab use has showed that there's a higher local recurrence rate. But because almost close to 44%, which was shown by Professor Puri's paper in the BJJ, where post-neoadjuvant denosumab has a 44% risk of curettage. But if you do decide to curette, then we would recommend going early, as recommended by a paper by Dr. Manish Agarwal in CORR, where he said 2 to 3 doses minimum and then proceeding for curettage. But if you extend it beyond that, you will never be able to curette the the shell of the cavity, because you would have tumor cells seeding within the wall of the false bone which is formed because of denosumab.
Can I have a comment here?
Yes, sir.
Yeah. So the paper by Dr. Am I audible?
Yes, sir.
Yeah.
Yes, sir.
The paper by Dr. Agarwal, there's a great difference between the paper, the inclusion criteria of his cohort and the cohort at TMH. In TMH, the cases were selected very specifically, those which were borderline patients. And the patients where upfront curettage was seeming, it seemed a bit difficult. But in Dr. Manish Agrawal's paper, every comer was, every patient was given denosumab. So that was a great difference between the two cohorts. The conclusion which I think we should understand is that denosumab is not for each run-of-the-mill cases, and case selection is of prime importance. We don't use it for all our patients. We use it for borderline patients. I'm just talking about curettage patients. I'm not talking about unresectables and where we plan resections. And if you see the local recurrence between the two papers, the paper from Tata Memorial and Dr. Agrawal's paper from Hinduja, both had same amount of local recurrence. So what it says is that your case selection is very important. And what we inferred was that the patients which would have ended into resection, the patient where we felt that we can't do a good cure, we need to be just a bit careful when we are comparing these two cohorts. But completely agree with you that for all patients, we don't need it. We are, if you search denosumab, it is one of the most searched drug today and most research drugs with highest number of papers. And there are a lot of issues like how much denosumab to give, at what interval to give, can we decrease the dose? Because it actually works like immunotherapy, can just modifying or the milieu. So research is going on and we are still learning. Best, thank you.
Thank you, Professor Gulia, for your comments. I can see there's a question by Ashik Bari. Can an isolated lung nodule be watched in a case of metastatic GCT once local disease is cleared? Does denosumab have a role in this case? Can I get Professor Gulia to add to this comment before I? I think he's been cut off there. Yeah, so Ashik, it all depends on the balance of the morbidity of the resection for a isolated lung nodule. What we follow at ROH is if there is an isolated lesion on the lung and they're suspicious of giant cell tumor of bone, we would biopsy it first. And if it is resectable, we would offer that patient a resection to begin with, rather than waiting for the tumor to grow and then deal with denosumab. So upfront resection, if it is not too morbid, we would offer resection. If it is an unresectable tumor, then we would consider denosumab as a treatment setting. Any more questions? If not, we could move to the panel discussion now. I think we've answered anything else. Prateek, is there anything which?
Yeah, there's a new question which has come. You can just answer that last one before moving on to the panel. Comment on the usage of denosumab 120 versus denosumab 60 into 2 as those used in osteoporotic patient. Is there any difference in the efficacy?
Hi, Eric. That's a very good question. I think the denosumab 120 dosage which was done was based on a series of cases which they've done as a trial, starting with management of breast metastatic disease. I personally don't have any experience using denosumab 60 milligram for management of giant cell tumors of bone, but this is what we generally follow. And if you look at the FDA approval, it was approved for unresectable tumors with the argument of 120 milligram. But that's something maybe worth considering in future. We do sometimes taper the dose if the patient is being managed with long-term denosumab for spinal and pelvic giant cell tumors of bone. But that's as a maintenance dose where we do it as a trial and error basis. But I don't have enough evidence to tell you that 60 is inferior to 120. But 120 has been what is most centers following across the world. But yes, in a setting where we would have finance issues or you're trying to taper the dose, then we do sometimes lower them down. And we haven't had a bad experience so far. I think if I could get, I don't know if Professor Gulia is on the chat box. I could ask him if his experience in TMH with a smaller dosage has helped, or if anybody else who practices orthopedic oncology has any experience with a 60 milligram dosage for giant cell tumor of bone. Pratik, any comments? Michelle?
I think we can discuss this in the panel in more detail. Let us at least start the panel discussion.
Yeah. I think we don't have any more questions. We will answer this, and we'll bring this up again in the panel discussion. Now, I would like to invite my dear friend and colleague, Dr. Michelle Parekh, who is a consultant orthopedic oncologist practicing in Mumbai, MPCT, and we have a complex panel batch of panelists. I would like to invite Dr. Kaushik Nandi, who is a consultant orthopedic oncologist practicing in Calcutta. We have Dr. Navneet Kamath, a friend and colleague, who is a orthopedic oncologist practicing in Indiana Hospital, Mangalore. I would like to once again invite Professor Rajesh Bochu, a consultant muscular radiologist at Royal Orthopedic Hospital in Birmingham. Dr. Rajiv Reddy, who is a consultant orthopedic oncologist at Apollo Hospital, Jubilee Hills in Hyderabad. Dr. Subin Sugat, who is also the chairperson, who is a consultant orthopedic oncologist in Oak Hospital in Astor Medicity, Kochi. And Dr. Pratik Hegde, who is a consultant orthopedic oncologist practicing in Mumbai. I don't know if I would like to invite Professor Ashish Gulia as well to be on the panel.
I'm
for his comments. Yes.
Thank you so much.
Over to you, Dr. Michel.
Thank you very much, Vineet, and good evening and welcome to this panel discussion. We've had good 3 talks about introduction to the giant cell tumor, the management, its principles, and also a good discussion on denosumab and its role. Well, here we have some cases that would be seen in your daily practice, even as a general orthopedic surgeon during your residency, because like Dr. Subin said, that giant cell tumors are in today's time managed by orthopedic surgeons as well, and we need to do a good job about it. So, we'll start with our panel. And I'll bring the first case here, which is the 24-year-old female laborer by profession, and she has a history of 1-month-old, pain in the shoulder, which has restricted her movements. And this is a dominant hand, and we'll see what the imaging looks like. So this is the X-ray and representative cuts of the MRI. Now, since we have Dr. Rajesh here, sir, would you just again brush up with the imaging findings and tell us why this is a GCT?
Yeah, so basically you can see a lucent lesion. It's a fused skeleton. The patient is after skeletal maturity, expansile going all the way to subchondral bone, and it's predominantly low to intermediate on all sequences. So given the location and everything, it would fit with the GCT.
And just like how Dr. Suman also emphasized that even though it looks like a GCT radiologically, everything fits the picture, but we should do a biopsy and prove it. So just for the sake of discussion, all the cases in this panel are biopsy proven GCTs. There are no bouncers here, and we are going to talk about how to go ahead with management and planning. So here, this is a proximal humerus giant cell tumor of the bone, and we have the X-ray and the MRI findings. So now the thought process has started. So I would like to invite Dr. Rajiv and just help us that what would you plan for this patient right now? What is going in your head once you have got the report that it is a biopsy proven GCT?
Yeah. Hi, Nikhil, and thank you to Sarcoma Education Foundation for involving me in this wonderful teaching session, as well as Dr. Gulia sir and Dr. Vineet. As this is a biopsy-proven GCT and it's a young patient, my initial thought process would be that I would like to excise the full tumor. At the same time, I would like to make sure that he retains his shoulder joint as far as possible. In this particular situation, it looks like it's a little difficult because of the big soft tissue component, and he has very little of the subchondral bone remaining. But my thought process would be that I would like to save his shoulder joint and try to curate and excise the soft tissue component of the tumor, while at the same time trying to retain the subchondral humerus.
Okay. So, Dr. Subin, would you conquer or would you have a different plan?
I think he's I think he's got he's answering a call. He's just off.
Okay, okay. So Vineet, can you just what would be your thought?
Can you? Sorry, I just lost you there. Can you just repeat the question? Thank you.
Yeah, so like Dr. Rajiv said that a young patient, he would want to save the shoulder joint and attempt the curettage, saving the shoulder. I just wanted to know if you are thinking on the same lines or you have a different thought process here.
So this is obviously a Campanacci 3 because I can see there's a cortical breach on the inferior aspect of the humerus. This is borderline in terms of its salvage option, but this would be one of those cases where I would consider a salvage of the humerus because loss of function for the humerus is quite significant. So I would discuss the options with him, and if he agrees the acceptance of the higher risk of recurrence, then I would consider giving him. But I would need some form of neoadjuvant treatment before considering any surgical intervention.
Okay. So this is what everybody thinks, and this is the right thing to do because saving the proximal humerus or the shoulder joint is of utmost importance. And so this is what was thought for it. Everybody on the same lines. We thought let's embolize this and see what can we do. We embolized this patient. Patient was not affording for a denosumab that was offered to him or to her, and
இங்க பாருங்க சார் இது இந்த மாதிரி ஆன்ஜியோ எம்பலைசேஷன் அண்ட் டெனுசுமாப் தான் வந்து அட்வைஸ் பண்றாங்க இனிஷியல்.
And then we had endocrine sort of considered. And does anybody feel that we should resect?
Your voice is a bit patchy, Dr. Michel. We lost you there.
Yeah.
Michel, you'll have to repeat that question. Michel, you're not audible. Michel, I think we have lost you.
So am I up now? Yes. Can you hear me now?
Yes.
Okay. So now this is embolized. 1 month post embolization, we have this X-ray, and this looks like a responding lesion, and our plan to curate it is on course. Anybody on the panel would like to have any other thoughts right now, or can we go ahead and do a joint sparing intralesional curettage for this patient? Dr. Navneet, could you answer that?
Yeah. Michel, the only worry. Am I audible?
Yes, yes.
Yeah, the only worry in doing a curettage for this upfront is a massive bleeding. We cannot apply tourniquet for obvious reasons, and these tumors are very hypervascular, and it's already been a month since the angioembolization. So I would prefer, if you're not giving a denosumab, I would say you do a preoperative angioembolization and then you go ahead with an extended curettage and salvage this joint.
Okay, thank you. So, I mean, that was exactly what was done. Before the surgery, another embolization was done, and within 24 hours, the surgery was performed. Now, so this is what was done for the patient, and curettage was done, and umbrella construct kind of an allograft was put where the femoral head takes the shape of the joint of the shoulder joint, and the strut graft comes into the diaphyseal area fixed with K wires, and we let it consolidate in place. And if you see here at the end of 2 years and 3 years of follow-up, this has healed very well. We've not had a recurrence, and we have maintained a good range of motion for the shoulder joint. I mean, anybody on the panel would have any difference of opinion about the treatment offered to the patient?
I would like to. I mean, I think this is an excellent outcome, but I mean, 3-year follow-up for a giant cell tumor with a Campanacci 3 proximal humerus is an excellent outcome. But interesting, the technique which you mentioned today was a paper which I'd written with Professor Gulia when I was during my days in Tata, and we didn't have any local recurrence in that series. We had 2 cases, I think, in the entire series which had local recurrence. But I think now in practice, when I see a similar case, our first argument is the higher rate of local recurrence in these cases. I think we are very lucky with this patient, but I would have probably offered this patient neoadjuvant denosumab with a view for resection and reconstruction using a reverse shoulder, just because I would be too concerned about her risk of local recurrence.
That point is well taken. And a reverse
Can
shoulder
I
is.
have a comment?
Yes, sir. Yes, sir. Yes, sir.
Yeah. So, Vineet, thanks for your comment, but again, I beg to differ with you on this. The reasons why I say so is that if we have to give denosumab and we have to do resection and do a sort of non-biological reconstruction, it can have its own issues and failures, and especially the cost related to it as well.
Yes, sir.
So what do we lose if we follow this, and if we get a recurrence? Now you only have it on a paper, and out of 14 patients you had recurrence in 2, and you could salvage rest of them. If you get a recurrence, you still have the option of re-challenging with denosumab and doing a reverse shoulder, but still you can maintain the biology in rest of them. What's your comment on that?
Sir, absolutely. I mean, like I said, it's quite amazing that this patient got a 3-year follow-up. My rationale for doing why I would give resection is, one, I think the soft tissue component on the medial aspect is very close to the vascular bundle. It is a Campanacci 3. I don't think I could clear away all that disease without offering a resection. Point is number one. Second, I do agree that cost is a factor which has to be taken into account when you're managing cases in most parts of the world. But the risk of recurrence is not my only concern. The risk of potential having metastatic disease, as we know that the risk of metastatic disease to the lung would increase with recurrent tumors. And doing a revision surgery, the increased risk of infection with a higher risk of local recurrence, for me, would be against offering a biological reconstruction in this patient. I think I showed a similar case. I showed a similar case in my series as well, where we had a similar patient. I think that was not as that was borderline Campanacci 2, going just cortical breach, and our decision for offering her resection was because of the fact there was an increased risk of local recurrence. But I mean, like I said, excellent outcomes for this patient. So hence, retrospectively looking, I think it was the right decision. But I would still favor, if it's a Campanacci 3, if I can't resect, my suggestion would be a dissection.
Okay, so this is another case in a similar kind of construct and a similar kind of outcome. The only point that I wanted to stress here is the fact that proximal humerus, like Dr. Rajiv said, we should always attempt to save the joint. And there have been certain literatures on that where the functional outcome and the scores have been higher for patients who've been conserved. I mean, the joint has been conserved compared to the resections. This is another mode of reconstruction where the cavity is completely filled with cement. No sort of implant has been used here. And so the learning from a proximal humerus giant cell tumor for me is that you need embolization before surgery, because these are vascular tumors, they bleed a lot. The feeders to the vessels, when they are embolized, your surgery becomes easy when you do not have denosumab also as a weapon for you. Joint preservation always gives a better outcome compared to even a reverse shoulder or a conservative hemiarthroplasty of the shoulder joint, where you lose overhead abduction and certain functions. Allograft is a good option for a proximal humerus because it is a non-weight bearing bone. You can keep the arm pouch for 4 to 6 weeks. You can allow the graft to consolidate and get good outcomes. We'll move on to the next case here. And the case is a 22-year-old female housewife. She has a wrist swelling, restricted movements due to the pain, and it is the non-dominant hand. We'll quickly go to the X-ray. And again, I would invite Dr. Rajesh to just, brush up with the findings of this X-ray.
Yeah, again, what we can see is, in this case, lucent lesion, narrow zone of transition, going all the way to the subchondral bone of the distal radius. It's expansile. So again, classic features of, we can see some trabeculations as well. So again, classic features of GCT.
Okay, sir. So we have this X-ray, and then we have the MRI, which shows the soft tissue extent and the component of this disease. And if we have Dr. Subin back, I would like to ask him that what does he feel looking at this MRI? Okay, so he's not with us. Dr. Navneet, can you just give us some what you feel about this MRI?
Yeah. So though lengthwise it's not much of a disease involvement, you can see that there is soft tissue grossly circumferentially in the distal radius. Can you go back to the X-ray? Yeah, there is a large volar soft tissue component. There is a large soft tissue component on the radial side. Also, there seems to be involvement of the radiocarpal joint also. So this is a very extensive localized disease. So yeah, I think we'll go ahead with the resection. I think everyone here would prefer a resection, considering that this is being a very difficult type of curettage, known to behave aggressively, very high chance of local recurrence. Yeah, I think I would go for a resection.
Okay, so Dr. Rajiv, here we have urged towards resection right now, looking at the imaging. Would you want to add something about going for the resection upfront, or would you want to do something to convert this resection into a curettage, knowing that losing the wrist joint would be sort of a handicap when you cannot have movements at the wrist joint?
No, in this particular case, I would prefer resection over curettage. I do agree that the patient will lose some wrist movements after arthrodesis, because ulnar translocation by default causes fusion of the wrist joint because of the long plate that we place from the metacarpal across the carpals into the distal radius. But the function after wrist fusion and ulnar translocation is so good, and they have such good hand grip and power, that we have seen this in the previous papers that have been published, that there's no reason not to do an ulnar translocation and wrist fusion, because the patient will not have any functional disability. And most importantly, after curettage, the chances of recurrence in distal radius in the best of hands is quite high. So we would not want to risk a recurrence, such a high risk of recurrence, when we have a surgery like ulnar translocation, which not only reduces the chances of recurrence but also gives a very good functioning hand. So I'll definitely go for resection, ulnar translocation, and wrist fusion.
Okay. Dr. Vinny, this patient is not willing for a resection and an arthrodesis, and the patient wants to know that even though she's willing for a high chance of recurrence, can you curate this and salvage her wrist joint here?
I think, thank you, Dr. Michel. I think this reminds me of one of the questions which Professor Puri and Professor Gulia used to commonly ask us in terms of how do you decide whether this patient is for curettage or resection. I think there's something described by Cheng's criteria. I don't think this patient is worth is amenable to curettage because there's extremely high risk of local recurrence. But by Cheng's criteria, like how Dr. Navneet explained, you have soft tissue component in 2 planes, you have cortical destruction more than 2/3, and possible intra-articular involvement. I think this patient would best benefit with a resection, ulnar translocation. I didn't see the resection length, so if it's less than within 5 centimeters.
So we'll come to the reconstruction, but everybody on the panel agrees that this is not amenable to curettage and resection is ideal for this case. Dr. Vinny, just because you mentioned Cheng's criteria, just in brief, for the audience, just tell us the 3 points so that they can, register it again.
Yeah, so Cheng's criteria is basically a paper which was done, I think, in 1995 or so, where they looked at 12 patients with Campanacci 3 giant cell tumor of bone. And the criteria where they decided for resection versus curettage was if the patient had joint involvement, that is articular involvement, where the patient had involvement of the cortical bone more than 50% destroyed, and if you had soft tissue component in more than 2 planes, then those patients would benefit with resection, as that would be the least chance of the disease coming back.
Yes.
So I'll repeat that: articular involvement, soft tissue components in more than 2 planes, and presence of and cortical destruction more than 50%.
Yes. So if any of these 2 are positive, then you will never curate and go for a resection. And that is what the whole house feels, and that is what is correct. And that is what was done. We had these questions in mind that should we give denosumab or zoledronic acid and give the patient a chance towards curettage versus resection upfront or post neoadjuvant, arthroplasty or arthrodesis. This is what we'll come to right now, because the decision for resection has been made. I would like to, like Dr. Rajiv has very, clearly said that ulnar translocation, although an arthrodesis gives a good function. Would anybody want to comment in favor of arthroplasty or something about arthroplasty that our audience should know? Okay, so what I would like to comment here is that in orthopedic practice, we have seen a lot of orthopedic surgeons who rely on resection and a fibular arthroplasty, where they harvest the fibula, and because it resembles the distal radius joint, they put the fibula there and expect a good range of motion at the wrist joint, versus an arthrodesis that most of the orthopedic oncosurgeons do, an ulnar translocation or an iliac crest bone graft, or maybe an ulnar centralization, depending on the length of resection, as Dr. Vineet was talking. Here we will discuss what has been done and what should or could have been done. So this is what was done, a clear-cut case of ulnar translocation, because the length of involvement or the length of resection is what will decide what you do in terms of your reconstruction. So I would ask Dr. Navneet that, what would be your cutoff measurements for all of the 3? I mean, when would you use an iliac crest? When would you not use it and go for an ulnar translocation? And when would you do a ulnar centralization?
Yeah, when it's a very short segment resection and a reconstruction, usually about 5, not more than 6 centimeters, we prefer to do an iliac crest graft and a wrist arthrodesis to either a second or a third ray. The reason being, longer the length of reconstruction required, you will not get a straight tricortical iliac crest graft. So these are basically technical reasons. And anything more than 5 to 6 centimeters, we would prefer an ulnar translocation. A long segment, though there is no measurement, I would say it's a subjective assessment. A long segment of radius, when resected, we do prefer to do an ulnar centralization. The only reason being there is a risk of decreasing the vascularity of the transposed ulna. So most of the cases we do prefer an ulnar transplantation.
And you'll
Yes,
also
so
lose pronosupination because of centralization.
yes. So centralization is probably the one that would give you the most inferior outcomes in terms of function, but that has to be done if your segment of resection is more than 10 centimeters, because otherwise your, the translocated ulna will not unite and again give you no functional outcome. So what I would, summarize it as, if the resection is less than 5 centimeters, you go for a iliac crest bone graft. If it is between 5 to 10 centimeters, you go for a translocation, and anything more than 10 centimeters, you would do an ulnar centralization. Now, again, there are some other examples of distal radius, lesions of GCT that we have. Now, this is just put to compare the case that we just spoke about had a large soft tissue component. It had cortical breach and an articular involvement. In this case, if Dr. Rajesh would chip in, that how would you differentiate this lesion to the lesion that we just discussed in terms of the size and the aggressiveness? Okay, so the purpose of putting this X-ray is just that here you can see the lesion where the articular cartilage is intact. It has probably not breached to cortices and come out as a soft tissue component. Maybe one of the cortex is very thinned out, and so in this case we can go ahead with a curettage and save or salvage the wrist joint. And this is what can be done. You put in a cement and screws for the structural support. And the learning from this case of a distal radius giant cell tumor is that we should know the Cheng's criteria to know when to resect and when to curate. And this is just a point that I've put because a popularity of a fibular arthroplasty is too much in the orthopedic population. And as an orthopedic oncosurgeon, we have seen that long-term outcomes of this arthroplasty is bad. The arthrodees, patients have a lot of pain, and upfront arthrodesis with centralization or translocation has given good results. I have one case which I have seen during my training days at Tata Memorial Hospital, where this is a young female, I think 18 years old, college going. She has written her exams 4 months after the surgery of an ulnar translocation. You can see she can write very well with her operated hand, and you can see the function of the operated hand compared to the normal hand. This is 6 or 8 months after her index surgery. So let's move on to the third case. And this third case is a 35-year-old male.
Sorry, Dr. Mishra.
Yes.
Is this your is this your last case? Can you make it?
So I have 4, but we'll go fast here. Okay.
Yeah, no problem.
Yes. Okay. So this is a 35-year-old male with history of blunt trauma to the knee. Again, a biopsy proven GCT, but this case is put here because of an intra-articular fracture through the disease. And if you see the imaging here, you can see it is more or less contained. Just because of the fracture, it has spread a little bit in the fracture plane. Not much of an articular involvement as such if you see the disease carefully, but again, an intra-articular fracture through the disease, you're always worried about contamination into the joint. Now, again, looking at this, I'll go back to the imaging, but these are the questions that I have put forward. That would you give neoadjuvant splint and then operate later? Would you go for an upfront surgery? And if surgery, what surgery? This is the MRI, and this is the X-ray. Dr. Rajiv, can you just take this up, please?
Yes, Michelle. This patient has a GCT of the lateral condyle of the distal femur, and even though there is a fracture in the intercondylar region, I still feel that we can do a joint salvage surgery because there's a decent subchondral bone remaining. So my plan would be to do a curettage from the lateral aspect, to do a curettage and subchondral bone grafting and bone cementing. I'll also keep a distal femur plate ready and assess the stability after cementing, after bone grafting, after the curettage essentially, and assess depending on how strong the cortex is, whether a plate will be required or not. But essentially, it will be a curettage and a sandwich technique.
Okay. So, Dr. Vinit, since you are the denosumab man, would you do an upfront surgery or would you want to give denosumab?
Depends on how long this patient takes to reach me after the fracture. I think I agree with what Dr. Rajiv said. If this patient presents acutely with a similar presentation, I would offer her upfront surgery, reduction, reduce the articular surface, and then do a sandwich technique. So I would do bone grafting and cementation and plate.
Okay. So again, we all are on the same page here. Upfront surgery, like he said, depends on when the patient presents to you. Considering that the patient had the disease but got imaged only because of the fracture, I'm sure he would not waste time and would come up as early as possible. And upfront surgery should be done here because, if you let this disease wait for gumming up, you will have more difficulty in the curettage in terms of disease clearance. You might feel that you have cleared enough, but you might leave behind disease there. So I would stress on the point that upfront surgery should be done irrespective of a pathological fracture in giant cell tumors. We have all discussed and decided that this can be curated. I would now ask Dr. Navneet to highlight because he was kind enough to share this case with me for discussion. And Dr. Navneet, please take over.
Yeah, so this lady had come immediately after the pathological fracture. She had no major symptoms before the fracture. And she was a 34, 35-year-old lady. And this was her primary presentation. And no open biopsies, no other form of contamination was done. And the disease, there was some hemorrhage in the joint, but there was no gross disease as such. So as Dr. Rajiv and Dr. Vineet mentioned, we did an upfront curettage from the lateral side. Post curettage, as you can see, there is no half of the posterior cortex. There is absent half of the anterior cortex. The condyle is grossly unstable, though the lateral collateral ligament attachment was intact. So the condyle was hypermobile, but we still plan to save it with the reconstruction in the form of intraarticular cement and plate. So we did a plate fixation first. The reason being we wanted to stabilize the condyle before we put intralesional cement. The thing is, I put the plate inside the condyle here, so to prevent medialization of the condyle, we put some cross-canceller screws and we put some gel foam in the intercondylar notch area and the posterior aspect to prevent any thermal injury to the posterior neurovascular structures and any cement leak into the joint. The post-op X-ray looked good, and she's. Can show the next X-ray. Dr. Michelle. Yeah, this is a follow-up X-ray at about 1 year. 1 year, and she has minimal knee stiffness, but overall she's managing very well. She's disease-free, luckily, and we hopefully we hope that she doesn't have a disease recurrence anymore. But yeah, I think this is the best we could do with the current available situation.
So thank you very much, Dr. Navneet. And the message here is that in a pathological fracture in giant cell tumors, do not wait. Upfront surgery should be done. Obviously, we should not risk a lot of disease left behind. Do a thorough curettage, thorough clearance of the disease. These are some other examples of distal femur lesions where the disease is not very extensive. It probably was not breaching the cortex, picked up very early. You can put in screws as well for structural support with cementing, and the normal hockey plates and cement like we have discussed, where the subchondral bone is enough. Do we have time for the fourth case?
I think we're just running a bit short
All
on
right,
time.
fine. So
can I just ask
yes.
one question to the panelists? Is there
Yes.
a point where you would decide not to stabilize the lesion with a plate? What is your threshold for deciding this post curettage that a plate would be required for augmentation?
Vinny, can I answer this?
Yes, please.
So though we keep plate, cement, bone graft, everything standby, even K-wires, I think post curettage, the amount of host bone remaining, the amount of stability, and the risk of fracture of that frail condyle, it is what makes us decide whether we need to put a plate. Though I'm not sure of any published criteria as such, but anything more than 5 centimeter, about more than one third of the loss of cortex, I would prefer having a plate for additional stability.
Okay. Does Dr. Michel, is that the same criteria for you as well? If you decide to
Yes,
augment
yes,
a plate
yes.
reconstruction, okay.
Yes.
So for us, it's a very general rule. If your post curettage cavity is less than 50% of the midline, then we sometimes defer from using a plate. But if the post curettage cavity is more than 50%, that is across the midline, then we definitely use a plate.
Dr. Mission, there is a question on the chat box. If you can just address that.
Can I make a comment?
Yes, sir. Please.
Yes, sir.
Yeah. So I agree with Vineet. 50% may be the criteria, but usually in our practice we end up anything above one third. We are quite aggressive in putting late, and the reason is that we don't lose much by putting an extra weight, and gives quite a lot of satisfaction. So first it may be about 30% or one third of the text versus the 50%. This is what we do at TMH. And regarding pathological fracture, I just want to make
Professor Gulia, you are breaking up. I think we lost you at the plate bit. So we lost you at the plate. You said one third, and then your voice chopped.
Okay. So the criteria for us is one third as compared to 50%. What we said, and aggressive in using a plate, it doesn't take much time. I want to make a comment regarding the pathological fracture for the audience. Please think that all pathological fractures, you cannot categorize them in the same category. It's different. Having an extra articular fracture is different than from having an intra-articular fracture. Having an undisplaced intra-articular fracture is again different from having a displaced articular fracture. But yes, the case which Dr. Michel showed clearly indicates that if you have
I think we lost, sir.
I think we lost Ashish sir again. Dr. Michel, one last question. I think.
I'm sorry.
Yes.
I'm sorry. Please continue. I think my network is weak. You guys, please continue. But just don't categorize pathological fractures in the same to give them a personalized treatment.
Yes, sir. Point
Thank
taken.
you.
Point taken. We have one last question for the panel. Plate screws, when you're applying for cementation, do you normally put the screws in first and then put cement around it? Or do you wait the
So that is what we do. Even if you saw the
or do you wait for the cement to set and then drill holes through the set cement and then plate and then screw it?
Yes. So if you saw the Siam picture in the previous case, we have done the screw and the plating before we put in the cement. The logic behind this is that when you drill through the cement, you are weakening the mantle, and the whole purpose of the cement being there is lost. So we would do the plating first, put the screws in place, and then pack that cavity with cement, which was also shown in the video that Dr. Suman had done. The instrumentation is done first and the cementing is done later.
Okay. So basically, Dr. Mitchell is trying to say that if you're pre-drilling, if you drill it after the cement is set, your risk of causing a cement mantle fracture is higher. So we would recommend putting in screws just for structural stability at the time of solidifying of the cement. Is that correct, Dr. Michel?
Yes.
I think that has been an extremely productive session. I would like to thank Dr. Mitchell on behalf of the Education Foundation for sparing his time for moderating this session, and to all the panelists who have provided their valuable input for this session and made this productive. And I'm hoping the entire August audience here today has benefited with the cases which have been described. Thank you, Dr. Mitchell.
Thank you. Thank you.
I would like to now start introducing Dr. Pratik Hegde, who is a consultant musculoskeletal oncologist from Mumbai, a dear friend of mine, who is also our quiz master for today. I think this is the last bit of today's session. Over to you, Dr. Pratik.
Thank you, Dr. Vineet, and thank you to all the panelists for that wonderful talk and for those wonderful case discussions. I believe we had a good, healthy discussion, and now we are running short of time. So let's not waste a further time and get to this fun part that we have designed so that the participants and the delegates who attend this can have sort of like a reminder of what was taught, and also to add a little fun element to this. So this is the Kahoot quiz, and I would request all the participants to download the Kahoot app. This is a separate app which is available on your app store, and you can just download that app to play the next quiz session. What we'll do is first play a demo session to know how this game is played, and then we'll come to the main session. So I would request all the participants to download the Kahoot app, and we can then start to see how this goes. Dr. Vineet, I would request you to stay around so that you can then discuss the answers. Yes, sir.
The one thing I want to announce today that, let people know that after 12 sessions, we're gonna have an overall winner. So people who attend all the classes, the people who attend all the Kahoot quiz, and if there is someone who attends everything and scores higher, so we have a mega bumper prize at the end of the 12 sessions.
Oh, great. So that is an added incentive for the participants to join us for this quiz. So what I'm going to do, I'm hoping my screen is visible and you can see the game pin that is being shared now.
Yes, sir.
So yeah, so this is for the demo quiz. The game pin is 5211814. So I would request all the participants to download the Kahoot app and to join us in this quiz. You can enter this game pin 521184. Please enter the correct details because that helps us in knowing the winner subsequently. And as Dr. Ashish has mentioned, there are prizes to be won. We have around 80 delegates who are participating, so I'm hoping at least 40 of them join us for the quiz. This is the demo quiz. So the purpose of this quiz is that you answer correctly and you answer it fast. So the app calculates the winner based on the points, and the points are allotted based on how fast you answer and how correct your answer is. So I can see good number of participants joining. Around 12 have joined. So I would request others also to join. Dr. Vineet, I would request you to stick around for the main quiz because you will be helping us to discuss the answers. If there are any further questions on the chat box and all, so then I cannot see them. Maybe you can just address them in the meanwhile as we wait for participants to join. So this is, remember, the demo quiz. This is a practice quiz just to know how this game is played. There are many of you that I can see have already participated before, so they might be knowing through the drill of it. But for the new participants, we are going to just play this demo quiz of 2 questions. So I think I'll just start with the demo quiz now. Okay, I hope the screen is visible and I am audible. So the
Yes.
demo quiz. The first of the demo quiz. Who is the Prime Minister of India? Is it red, Amit Shah? Is it blue, Draupadi Murmu? Is it yellow, Narendra Modi? Or is it green, Rajnath Singh? The participants have 60 more seconds to answer this. Prime Minister of India. Is it red, Amit Shah? Is it blue, Draupadi Murmu? Or is it green, yellow, Narendra Modi? Or is it green, Rajnath Singh? Last 2 seconds, 1 second. And the correct answer is yellow, Narendra Modi. We have 11 participants who have answered that correctly. Don't worry, this is the demo quiz just to show. As you can see, depending on how fast you have answered, you get categorized on the higher podium position. So moving on to the second demo quiz. Which of the following is the national capital of India? Is it red, Mumbai? Is it blue, Kolkata? Is it yellow, New Delhi? Is it green, Bangalore? Last 20 seconds to answer this. This is the demo quiz, so don't worry, you can answer. This is just to show how the game is played. We have last 5 seconds before the answer is revealed. And the correct answer is yellow,
Birmingham.
New Delhi.
Birmingham.
So the demo quiz winner is highlighted here. So I hope now people got an idea as to how to play this game, and we'll move on to the main quiz. Congrats to Manish for winning the demo quiz. So now I will start the actual quiz. Just give me a minute. So the rules apply the same. You have to answer correctly. You have to answer fast. We will be generating a game pin for this main quiz. We would like maximum participation. Even the panelists can join just to try out their knowledge and to see how they have fared in this. So you have to download the Kahoot app, and this is the game pin that you have to enter in that. This is for the main session quiz. The game pin is 9124060. So come on, participants, show some enthusiasm and join in. We've got good 10 questions to answer, and we have got good prize money at the end of it. And as Dr. Ashish has now announced, there is now a prize money at the end of all the 12 sessions. So that's an added incentive to participate. As I mentioned earlier, we had around 70 to 80 participants in the main session. So at least expect around 30 people to join in. So we'll wait for a couple of minutes for more people to join in. So we have 18 participants till now. Come on, more people can join in. There's a good prize money to be won. We have got 2,500 for the first prize winner, 1,500 for the second prize winner, and 500 for the third place winner.
Is this in pounds or rupees?
Unfortunately, our budget is in rupees. We are not sponsored by the NHS, so it's not in pounds. It's in rupees. So if you can manage to convince someone to give in pounds, so then I think even the panelists will join in. So it's already 7:13 now. I'll wait for a minute more for others to join, and then we'll start with the main game quiz. The game pin is 9124060. Come on, participants, if you're still hanging around, then join us. Kahoot app, download it on the Play Store and enter this game pin 9124060. So I think we have given enough time for the participants to join. So Dr. Vineet, with your permission, we'll start.
100%. Please carry on.
Yes, yes,
yes.
yes.
Do we know how many people have playing the game?
There are around 20 who are playing the game.
Oh, I can see 55 participants there. Come on, I mean, yeah. No problem.
So the first of the session quiz: which of these mimic a giant cell tumor of bone on imaging and biopsy? Is it red, Paget's disease? Is it blue, multiple myeloma? Is it yellow, primary hyperparathyroidism? Is it green, renal osteodystrophy? Last 10 seconds to go. Mimic giant cell tumor of bone on imaging and biopsy. Is it red, Paget's, blue, multiple myeloma, yellow, hyperparathyroidism, or green, renal osteodystrophy? The correct answer, as we know, is primary hyperparathyroidism. So, Dr. Vineet, if you can just explain that point.
Am I audible now?
Yes, yes.
Yes, I think today's entire point of the meeting was for people to understand what are the common differentials for giant cell tumors of bone. As you can see, is this X-ray relevant to this or the next case?
No, this is just an example.
Okay, so if you can see, this is an AP radiograph of a skeletally mature person. There's an eccentric lesion. There's a bit of cortical expansion there. Classic on radiology, if someone asks you what do you think this is, this could be called a giant cell tumor of bone. Now, if in the differential, why primary hyperparathyroidism is very important is occasionally Brown's tumor would present in a very similar manner. So 5% of patients with hyperparathyroidism could have a Brown's tumor, which is basically lytic lesions with similar radiology, similar pathology imaging. And it's sometimes very important as clinicians when you see such cases to make sure that you check a very simple investigations, looking for the serum calcium levels and parathormone levels. You would have serum calcium and parathormone levels abnormal, elevated in cases of hyperparathyroidism, whereas in GCT, everything should be within normal limits. So it's a very simple test. So just because you see a lytic lesion, please don't biopsy it. Sometimes a biopsy will come back with similar features of a GCT, but always check for blood parameters if things look abnormal. When we say abnormal, age, presentation. So elderly patients above 40 presenting with features similar to this, please make sure that you get the blood levels checked. It's a simple test and you can get away from doing anything dramatic for the patient.
But how does it matter to the overall management?
So, for example, if it's a hyperparathyroidism, the basic pathology is not the tumor itself. The patient could have a parathyroid adenoma. Patient could have a parathyroid carcinoma. So we have to identify the cause of his hyperparathyroidism and treat the cause. And once that is treated, most of these conditions resolve spontaneously without any surgical intervention from our side. There could be occasional cases where patient could be debilitated, in which you could offer some form of intervention, but at the most, you should leave it alone and they spontaneously heal.
Yes, thank you for that. So at the end of the first question, we have got NK who is leading. Let's move on to the next question.
I think I know who NK is. I think he should be disqualified from this quiz. But
what is the Campanacci grading of the following lesion? Is it red, grade 1? Is it blue, grade 2? Is it yellow, grade 3? Or is it 4, grade 4? Green. Is it red, grade 1, blue, grade 2, yellow, grade 3, or green, red, grade 4? Last 8 seconds to answer this. We are now down to, now everyone has answered, and the correct answer is grade 2. Dr. Vineet, if you can explain that, please.
I think everybody knows this, I think, after today's class. So Campanacci obviously is what we follow for grading of giant cell tumors of bone, grade 1, grade 2, grade 3. Grade 1 are intraosseous tumors, cortex not involved. There's no expansion of the cortex. In this case, you can see that it is not. This is just a bit of cortical expansion, but the essential tumor is intraosseous. So just because of the fact that there is a cortical expansion without any destruction, I would grade this as a grade 2. Anything less than that would be a grade 1. And the moment there's a cortical breach with a soft tissue extent, it would be a Campanacci 3. And that's something which is important from a management point of view, because as we discussed today, 1 and 2 could be treated with curettage plus or minus cementation or bone graft, depending on practice of choice in your center.
Yes, and as we know, there doesn't exist a grade 4 Campanacci. So moving on to the next question. Question number 3. Which of the following is not epiphyseal in location? Is it red, clear cell chondrosarcoma? Is it blue, giant cell tumor of the bone? Is it yellow, aneurysmal bone cyst? Or is it green, chondroblastoma? Not epiphyseal. Is it red, clear cell chondrosarcoma? Is it blue, giant cell tumor of bone? Is it yellow, aneurysmal bone cyst? Or is it green, chondroblastoma? Last 2 seconds left to answer that. Majority have answered it correctly. That is the aneurysmal bone cyst, but we still have some confusion among the answers. So Dr. Vineet, if you can just clarify that.
I think this quiz is not meant for these people. They're answering every question correctly. I don't think I have much to add, but yes, absolutely correct. Aneurysmal bone cyst, again, depends on whether it is primary or secondary. I think we should have just specified that perfect. Primary aneurysmal bone cysts are basically seen in these skeletally immature adults, and it's generally metaphyseal location extending towards the epiphysis, if anything. Whereas the other differentials are classic of a giant cell tumor of bone. You could have a giant cell tumor of bone, which is eccentric epiphyseal. You could have a chondroblastoma, which is centric epiphyseal. And if anything above the age of 25, 30, and you have a lytic lesion around the femoral neck or head with a epiphyseal or apophyseal location, clear cell chondrosarcoma should definitely be considered in your differential, because the management for giant cell tumor of bone is completely different to that of a clear cell chondrosarcoma, where you need a wider resection for its surgical treatment.
Yes, thank you for that. Moving on to the 4th question, we'll have a look at the scoreboard at the end of 5 questions. What is the incidence of metastasis in giant cell tumor of bone? Is it red, 0 to 5%? Is it blue, 10%? Is it yellow, 20%? Or is it green, never metastasizes? Incidence of metastasis in giant cell tumor of bone. And the correct answer is 0 to 5%. Majority have answered it, but Dr. Vineet, your expert comments.
I think absolutely correct. Again, 0 to 5% incidence of metastasis in GCT. I think I just wanted to confirm something, that obviously 1 to 4 is what is mentioned in literature. Now, just because we're calling it metastatic, it doesn't mean that they are metastatic. They are deposits from the same primary tumor. So they're generally called as benign pulmonary implants. So if you look, or if you review literature and you see giant cell tumor of bone with metastatic disease, they would rename that as benign pulmonary implants rather than metastatic disease itself. So it doesn't mean that the treatment has changed. The treatment would be purely based on symptoms and resectability. Yes.
Yeah. So moving on to the next question. And we have NK still leading at 3764 with IRK and Krishna close behind. Urging others to buck up and to catch this NK. Moving on to question number 5. Gene mutation seen in majority of giant cell tumor of bones. Is it red, KIT? Is it blue, EGFR? Is it yellow, H3F3A, that is histone? Or is it green, KRAS? The gene mutation seen in majority of giant cell tumor of bones. Is it red, KIT? Is it blue, EGFR? Is it yellow, H3F3A? Is it green, KRAS? 3, 2, 1. And the correct answer is H3F3A. So Dr. Vineet, if you would be kind enough to clarify this.
I think we have a very learned audience today. They answer all. They are well educated in terms of the correct histone mutations. But yes, correct. If you look at KIT, EGFR, and KRAS, they're all tumor markers for malignancies, i.e. carcinomas, whereas H3F3A is a specific histone mutation you see for benign tumors of bone. And classically, it's called as G34W, which is classic of giant cell tumor of bone. So that's what we sometimes use nowadays to differentiate giant cell tumor of bone from giant cell rich sarcomas. And 96% of the cases would have a positive histone mutation with H3F3A, that is G34W.
Yes. So
Just a fun fact, there's something called as H3F3B as well, which is also a histone mutation, but it is more specific for chondroblastomas rather than giant cell tumor of bone.
yes,
Just
thank
if
you.
someone is interested in knowing.
Yeah, and as you mentioned, the significance is in the radiologically similar lesions can be differentiated by just doing this one mutation on histopath, and you will get your answer as to GCTB. So moving on to the next question. We are on to the question 6. Denosumab acts against, is it red bone morphogenic protein? Is it blue osteoprotogerine? Is it yellow rank? Or is it green rank ligand? So red BMP, blue OPG, yellow rank or green rank ligand, and majority have answered it correctly as a rank ligand. So Dr. Vineet, your talk on denosumab seems to have had its effects.
I know. Thank you for everyone.
So I think we'll move on to the next question.
Yeah.
Before that, we have the scoreboard here where NK is leading, Erika is second, Parry has moved up, and there is some changes in the. Come on, participants, buck up. We need this last 4 questions to change your order or position. Which of the following has been proven to cause apoptosis of tumor cells in GCTB? Is it red bone cement? Is it blue zoledronic acid? Is it yellow hydrogen peroxide? Or is it green denosumab? Which of the following has been proven? Oh, people are answering fast, and the correct answer is zoledronic acid. Majority have answered it as denosumab. So Dr. Vineet, we need clarification here.
This is interesting. So if you look at denosumab is more tumorostatic or bacteriostatic. They don't have a tumoricidal effect. I think the question was very clear, which cause apoptosis of tumor cells in GCTB, and bisphosphonates by mechanism of action, they are apoptotic in nature. That being said, their role in giant cell tumor of bone is still not been completely proven. People have used it as local adjuvant agents post-curettage, but there is no study which conclusively says that it reduces local recurrence. So the answer to that question is correct, but for people who have answered denosumab is the adjuvant modality of choice, a new adjuvant modality of choice we use for GCTs, but it is not bactericidal, it is static, or tumoricidal, it is tumorostatic.
Yes. As mentioned, it's the in vitro studies which have found that zoledronic acid is cidal and denosumab is static. So this could be a game-changing question. Majority have answered it wrong. So skipping the scoreboard, I'm going to the 8th question. Which of the following is the physical adjuvant needed in extended curettage of bone? Is it red blunt curettes? Is it blue sharp curettes? Is it yellow low speed burr? Or is it green high speed burr? Extended curettage of bone, blunt curette, sharp curette, low speed burr, high speed burr. Which of the following is the adjuvant? Last 6 seconds to answer this. 3, 2, 1. And the correct answer is high speed burr. And we have everyone who has answered this. I think this is the first time that we have got a 100% correct answer. So people are listening to our talks and registering. That's good. Dr. Vineet, are you happy?
No, that's absolutely correct. So all blunt curettes, sharp curettes are all part of your initial curettage, which you use to grossly remove the disease and curette the side walls. The word we want to use is extended intralesional curettage, which is classically described using a high-speed bar. I think Dr. Suman had mentioned the RPM, but roughly it's around 60,000 RPM is what we
Yes.
look for when you're using. So if you are doing a curettage, you should ideally use a bar for curettage, and a high-speed bar with a rotary movement of about 60,000 RPM is what we would recommend as ideal.
Yes, thank you. So we'll have a look at the scoreboard. And NK has a streak of 8 correct answers in a row, and he's leading the scoreboard. IDK is a close second, with Barry third, KK Sukojo 4, and Dinesh Ravikumar. Come on, you still have 2 answers, and things can change, so don't lose heart. Please give it your best shot. Here comes the 9th question. 36-year-old male presented with the following X-ray. Which of these do not match with a diagnosis of GCTB? Red epiphyseal lesion, blue centric lesion, yellow expansile lesion, or green trabeculate lesion. You can see a distal radius lesion, lytic lesion. Which of these do not match with the diagnosis of GCTB? Is it red epiphyseal, blue centric, yellow expansile, or green trabeculated lesion? Last 1 second to answer that. And there is a split here. The correct answer is obviously blue centric lesion, but people have got confused with green trabeculated also. So Dr. Vineet, if you can just clarify and sort out the confusion.
No, I think centric is, so I think we probably should have shown you a different X-ray. I don't disagree with any of the 4 points. So we showed a distal radius X-ray today. And as mentioned by Dr. Bochu in giant cell tumor of bone in imaging, you could sometimes have a centric lesion in the distal radius, like we're seeing in this case. But a classic description of a GCT would not be called as, so it's classically eccentric, expansile, epiphyseal, with sometimes of trabeculations if you have a aneurysmal bone cyst component to it. A central epiphyseal lesion, which is what we would call as ideally a chondroblastoma in a skeletally immature adult. Rarely, you might have atypical infection, which could present in a similar manner. But yes, I think all 4 are decent descriptions considering the X-ray. But if you ask someone a giant cell tumor of bone in terms of what the answer would be, so it would be expansile, epiphyseal, trabeculated, eccentric. Centric would not be part of it.
Yes, it more alludes to that classical description: elderly, epiphyseal, eccentric, expansile, eggshell. So going by that, a centric lesion is not something that you match with a giant cell tumor of bone.
And like I said, he's 36. He's a male. As part of teaching, please mention that you have to check his serum calcium, alkaline phosphatase, parathormone, if possible, before proceeding for anything. Yeah.
Yes. So we are going to skip the scoreboard at this, and we're going to move to the last question, the final question. Come on, buck up, guys. Cheng's criteria for resection in distal radius includes all except greater than 50% of surrounding metaphysis is destroyed, articular surface is involved, neurovascular involvement, or tumor breaks through on dorsal and volar aspect. Which of these is not a part of Cheng's criteria? Is it red, greater than 50% involvement, blue, articular surface is involved, yellow, neurovascular involvement, or green, tumor breaks through on dorsal and volar aspect? And majority have answered correctly, neurovascular involvement. So Dr. Vineet, final explanation for this.
I think classic description, again, distal radius X-ray. I think if you can see, there's articular involvement. So 3 basic things. So this is a historical paper. This was something which we did in '95, and it's still being used because they were the only subjective way of identifying dissections around the distal radius. We're looking at 3 basic parameters. One is intra-articular involvement, presence of soft tissue shadows. So basically soft tissue shadows in more than 2 planes, and cortical destruction of more than 50%, which is what has been described. Neurovascular involvement is not considered a part of Cheng's criteria. And this is to decide if you want to do a resection or whether you want to offer curettage to the patient. But yeah, spot on. I think they've got it all correct.
Yes, that's good. So now we will reveal the final scoreboard. So on the second runner-up, third position is Barry. In second position is Enrique, and in first, who has been leading from the start, is NK. Congratulations, NK. And as is the norm, usually, we want the winner to share his experience. So if you can just switch on your video and help us know a few words as to how was your experience of participating. Okay, so there is a slight caveat here. NK was the panelist. Oh, Dr. Navneet Kamath is NK. So unfortunately, we cannot give him the first prize. So the first prize is now Mr. Irike, who is leading among the delegates. And if Mr. Irike is online, can you please switch on your video and share a few words, please? Mr. Irike, are you around?
Oh, hi, greeting. I'm Eric in Malaysia.
Hi, Eric. How are you? Hi.
Thank you so much.
Congratulations, first of all. And we would just like your comment on how was the quiz and how was the session in particular? Like, was it helpful? Any feedback that you would like to give?
For me, the session was awesome. That is why every month you'll see me joining, and I'm looking forward to this Kahoot game. So it's very interesting, really. Yeah.
Thank you. Thank you
so much.
Yes. So please join us for the next session as well. And the next session, as we know, is about management of malignant bone tumors, which will be on the second Saturday of January from 5:30 to 7 p.m. Chairman is Dr. Ashish Gulia, and it's being moderated by Dr. Suman Bairegowda. We have got lectures on how to work up suspected malignant bone tumors, role of chemotherapy, role of radiotherapy, and obviously we will have case-based discussions and the Kahoot app at the end. So I think that was a good session, Dr. Vinny, and with your permission, we would like to end it today.
Yeah, I would like to thank once again, Sarcoma Education Foundation, IMSOS, and the Bombay Orthopedic Society for this opportunity. I would like to thank all the participants, delegates who took the time on a Saturday to come in for this session and making it successful. I would like to thank the speakers, the panelists who, in short notice, were willing to come in and give their talk for today's conference. And I would like to thank Dr. Pratik Hegde for taking the initiative in organizing this, along with the mentorship of Professor Gulia in taking this forward. I think it's a brilliant platform, and I think a lot of people benefit, including myself, and hoping to attend future sessions as well. So thank you once again. Hope you all have a nice day and enjoy the France versus England match today. And I don't want to ask you who you're supporting, but have fun.
Yes. Thank you for that. And thank you to all. So with that, we end today's session. And that was the last of this year's session, in fact. Now we'll meet you next year in January. So hope to see you all and many more in those sessions. Thank you all. Thank you.
Thank you. Bye-bye.